Did you know that Chavostics and Trousseau's, we all know that they relate to calcium and they represent a low calcium level, but because of those relationships between electrolytes, they also can be observed in low magnesium because calcium and magnesium have a correlated relationship, and in high phosphate because calcium and phosphate have an inverse relationship. So I just wanted to say that Chavostics and Trousseau's can indicate those other two things. Hyperactive deep tendon reflexes are associated with low calcium, low chloride, low magnesium, and okay, so here's the trick. It's opposite. Hypo of these levels leads to hyper DTRs. The priority nursing intervention that is easy to forget about when dealing with electrolytes is providing general safety, like fall risk safety, seizure precautions. Seizure precautions then lead to airway like patency. So anyone with a level of consciousness change, tetany, spasms, neuromuscular changes, weakness, we have to remember that it's going to lead to breathing difficulty. And orthostatic hypotension is a fall risk. Burns, electrocution, and other similar trauma to soft tissues that leads to a lot of cellular death or lysis leads to which electrolyte imbalance? Hyperkalemia. 98% of potassium within a person's body is within the cells. When the patient endures trauma like this, you have millions upon millions of cells dying at once, spilling their 98% of the body's potassium into the blood in the interstitial space, and that can lead to major problems. And then we have cardiac problems because of that. Which electrolyte is lost from vomiting and NG suctioning? That would be chloride. 42% of all hospital treated electrolyte imbalances are for which one? So this is saying that if you're going to have an electrolyte imbalance in a hospital and get treatment, which one are you going to have? Or you have a 4 in 10 chance? That would be low sodium. And that is so counterintuitive because salt is everywhere. You would think, what the heck? How is it that so many people are having these issues with low sodium? The best I can explain it is because, again, so many exemplars deal with sodium and sodium excretion being in excess, and then too much water, like things like that. And then low magnesium is the second most common one from presumably alcohol abuse. Two relevant potassium sparing diuretics for our exams. Of course, spironolactone, but also amiloride, potassium sparing. All diuretic drugs lead to an increase in sodium excretion. True or false? That would be true. Thiazide diuretics are the worst about that, and loop diuretics are the best about that, but they all lead to increased sodium loss, which ties back to this one. The kidneys excrete which three electrolytes? Sodium, calcium, and potassium. Why am I mentioning this? Because renal insufficiency is going to cause these levels to be altered and go up because of diminished excretion. Sodium, calcium, potassium. Diabetic patients receiving insulin are at risk for which two electrolyte imbalances? Low potassium, because insulin and glucose take potassium into the cells with them, and low magnesium. I can't remember why, but diabetic patients are going to be at risk for our favorite, low potassium, and also critical hypomagnesemia. Patients on dialysis or with renal failure. What the heck? Did I literally double this up? Yeah, whatever. A critical nursing assessment for a low calcium level is the respiratory assessments. Low calcium causes laryngospasms, which then causes airway and breathing issues. So low calcium. Magnesium is needed for skeletal muscle contraction, carbohydrate metabolism, ATP formation. Well, that's a big deal. Vitamin activation, cell growth, and blood coagulation. So bleeding risk. All right, so magnesium, if it's low, we're going to be looking for increased bleeding risk. The actions of calcium in the body include, okay, I put these two slides together to show how similar cal and mag are. So we just looked at that. Now look at calcium. Oh, blood clotting, cardiac muscle contraction, skeletal muscle contraction, and bone strength and density. Yes, calcium and magnesium have very similar signs and symptoms when they're elevated or low, and they do very similar things. A client with acute kidney injury is at highest risk for which electrolyte imbalance? We've talked about this before, I'm sorry. When injured, the kidneys are also unable to produce and retain bicarbonate. Okay, so that's going to lead to an acidotic state with kidney insufficiency. This is going to lead to a retention of potassium. So this was just a focused way of saying hyperkalemia is associated with kidney injury. Hyperkalemia. While providing care to a client with a potassium level of 2.6, what body system is of greatest concern for critical changes? This one is tricky. I got this from Simple Nursing. It's actually the respiratory system. And we have to remember airway, breathing, circulation in that order. I know we go over potassium and its effects on the cardiac system so much, but I wouldn't be surprised if something tricky is on the exam about this. So I know what I'm going to prioritize. Loop diuretics are associated with potassium loss. Yes, loops, potassium loss. And also, they have the lowest sodium loss. Dark chocolate is a good source of which two electrolytes? This is a fun one, easy to remember. For select all that apply. Potassium and magnesium. So, but what about people who have too much potassium? Yeah, don't eat dark chocolate. Potassium and magnesium. All diuretics cause a potential for hypokalemia except the K-sparing ones. Is this true or false? It absolutely is true. Acidosis and alkalosis affect potassium levels in which direction? Alkalosis encourages low potassium. Acidosis encourages high potassium. And here is my memory trick. Alkalosis with a K, potassium, it has a low. So alkalosis lowers the potassium. You're never going to need to know that. But anyways. Albuterol and hyperthyroidism lead to this electrolyte imbalance. Low potassium. My goodness, are we ever going to stop talking about potassium? Beta blockers and digoxin may cause this electrolyte imbalance. I'm sorry, y'all. Okay, beta blockers and digoxin, elevated above 5, potassium. And then what was this other one? Albuterol and hyperthyroidism, low potassium. So we have a little spectrum going on there. I guess this would be relevant in if we were asked about a patient receiving digoxin, what's the critical electrolyte imbalance? High potassium. And I guess we would hold the drug. I guess so. Hyponatremia can result from these drugs. I feel like we've gone over this so much, but NSAIDs is not something I knew could cause low salt level in the blood, and the prills. I didn't know that. Dehydration leads all electrolyte levels to be elevated. True or false? That's absolutely true. Dehydration is going to make the whole panel, the whole comprehensive panel, go up. Tetany can be caused by low calcium, magnesium, because they're like little brothers, and chloride. Renal failure leads to these because of impaired excretion. So too much chloride, too much salt, too much potassium, all because they're not being filtered out by the kidneys. Too much, too much, too much. Chloride level mimics sodium levels except in pH disturbances. True or false? So sodium and chloride, we get those together in our food at the same time. It's been said that they follow each other and kind of their levels go up and down together, except for when the pH is off. Low magnesium stimulates. Okay, hold on. This is in reference to our relationship between cal and mag being correlated. So low magnesium stimulates parathyroid hormone release, which raises calcium and lowers phosphorus. And so this one card is very important to understand those relationships between cal and mag and calcium and phosphorus. Oh yeah, and I call PTH the the phosphorus trashing hormone. Just for now. Hypermagnesemia is usually only caused by these two factors. Too much intake in the form of antacids and renal excretion problems. So that's too much magnesium. I forget the name. Alka-Seltzer? Is that the one with magnesium? I can't remember. Milk of magnesia, of course. Long-term use of proton pump inhibitors causes what electrolyte imbalance? Too little magnesium. They're reducing the acid in the stomach, which impairs the absorption of calcium and magnesium. So, yes, that can lead to brittle bones. To manage hypertension with diet changes, we increase and decrease what electrolyte intakes? Obviously, sodium we decrease, but potassium, magnesium, and calcium actually have a blood pressure lowering effect. So we're going to encourage the patient to get whole food sources of these. They could overdo it with the potassium chloride at home, and these are really best absorbed through food. Before correcting low potassium, we first correct deficiency in which other electrolyte. They are totally related in the renal handling of these two. And so we correct the magnesium if it's low first, because the kidneys will just keep excreting potassium. I've heard it said that the kidneys excrete potassium kind of at a constant rate, even when it's low. They'll just keep putting it out, putting it out, putting it out. It's like they assume we're going to have a constant dietary intake.